So it was a Friday morning. The reference came from a resident. Said there was a case of acute kidney injury. The creatinine level came to 5. So what is the level? We have to stop the dialysis in this patient. Since patient received 3 sessions of hemodialysis so far. This was the question in the call. The topic of discussion is related to that, when to stop dialysis in a acute kidney injury. This is the topic for discussion. In acute kidney injury, first there is no urea creatinine cutoff to stop the dialysis. That is the absolute answer for the beginner level. Let us understand acute kidney injury and dialysis. If you take this AKI or acute kidney injury, hemodialysis might have been started for a particular reason. Before that, there is a diagnosis or probable diagnosis at the initial days why the patient went into acute kidney injury, either pre-renal, renal or post-renal. The etiology or the cause of acute kidney injury you should be aware of. That injury severe, that is why it led to hemodialysis state. Dialysis might have been started because of some reason: volume overload, uremia, electrolyte problem. Okay, out of these three. Any etiology, any particular case, let us take an example of pre-renal AKI. It improves as we give IV fluid. Usually, the time delay might be for the recovery might be different in different cases. Similarly, in renal causes of acute kidney injury, post-renal causes of acute kidney injury, the etiology should be treated. If it is renal cause, acute glomerulonephritis, immunosuppression might have been started. Once the etiology is treated, the patient will start responding. The most important parameter to look for is the urine output. If the patient etiology is treated, you found the etiology. If it is treated, the patient will come to the recovering phase. The recovering phase, most important is the urine output. Patient's urine output will be improving. Okay. The urea creatinine, the level might be static or it will start decreasing. It will take some days, 2 days, 3 days. Some patient drastically it can improve. For example, a patient was started on dialysis. You have to be very, very particular about the fluids, how much patient is receiving, whether it was removed during the dialysis or not. You have to put the patient into euvolumic status. If the patient is volume depleted, that is no fluid in the body, urine output might not come. So we have to give the fluid. Diuretic dose probably you have to reduce, because acute kidney injury, diuretic will put more stress on the kidney. Volume optimization, we can call it as technically. Okay. First, look for the urine output. Urine output will be improving. One question might come, sir, in AKI, in the beginning only patient urine output was fine. Now, the patient urine output, how we will compare? See, most of the acute kidney injury, urine output goes down. Only in very, very rare cases, urine output might be normal. Suppose in those cases, how to find out why the dialysis was started? If urine output is fine, unlikely for volume overload, it might be for dyselectrolemia, it might be for uremia. So by that you can match. So first look for urine output. Second, make sure the patient is electrolytically normal, acid base wise normal. If the kidney comes to the recovering state, usually these two almost always comes to the normal range. It won't be in a very severely deranged state. Significant hyperkalemia, bradycardia, acidosis, pH less than 7.1. These kind of situation won't be there. Recovering AK usually pick it up. Okay. Urine output, electrolyte, acid base status. Make sure patient doesn't have uremic symptoms. If dialysis was started and a question comes when to stop dialysis, that means patient might not be having any significant uremic symptoms. Here there is a catch. Don't take nausea and vomiting as uremic gastritis. It could be due to any drugs also. Significant uremic symptoms. When to say, if urea is more than 220 plus, creatinine more than 10 plus, there is a chance patient might be having uremic symptoms like encephalopathy, bleeding, pericarditis. These are significant symptoms. A mild vomiting doesn't matter much. Let us take an example. The urea is 220, creatinine is 10 plus. If urine output started coming, if electrolytes are stable, acidosis is not there, the values will start coming down, no need for dialysis. On account that you treated the etiology, it will start coming down. Don't worry, the graph, it will start from 220. Within one day, it might come to 110, it might come to 150, or it might take another 2 days. The graph might be plateauing for some time and will start coming down. So don't take any absolute urea creat value. Make sure patient is euvolemic, no symptoms in the sense electrolytically, acid base wise, and gross uremia. The levels will start coming down slowly. Okay. And one more point here I have to mention is hemodynamic stability. Patient have to be conscious oriented, and also blood pressure wise, pulse wise, have to be stable. Why I am saying this? The level of discussion is for MD student. A UG student or a technology who is saying, don't put any question in the comment, because they know if I say hemodynamically stable, because these are complex concepts where one is related to other. I can't give an absolute answer and explain everything in a short video of 10 minutes. Patient have to be hemodynamically stable per se. Make sure the renal parameters are not the reason for this hemodynamically unstable situation. And once the urine output started coming, leave out the urea creat value. If the etiology is treated, creatinine will start coming down. That is the time, no need for further dialysis. Any vascular access, if is there in the patient, either internal jugular vein or femoral, can be removed. Because femoral vein causes DVT, a source of foreign body is a hemodialysis catheter, so it have to be removed. So you can remove that. So that's all regarding when to stop dialysis in AK. So in summary, one thing I have to tell is urine output, electrolytically stable, acid base wise stable, urea creatinine values leave out, it will start coming down, you can stop the dialysis. So in the ground level, daily in and out, what is the problem or the thing that we observe is the volume calculation. If more volume is removed in acute kidney injury patient, that is ultrafiltrate, patient urine output will go down. What the medicine resident might think, urine output is going down, let me increase the diuretic dose. That again put the patient into AKI. So that part have to be taken into consideration. A very good volume assessment, and make sure you are not escalating the diuretic dose on condition that patient urine output is going down. Just look at the other parameters where the water has been removed, because in dialysis they might have removed it, because many a times technologists, if they didn't get the proper prescription, they might remove it. Okay, so these are all the things you have to take into consideration to stop the dialysis, because stopping the dialysis, a patient and their family will be so happy once the patient comes out of dialysis. So these are things you have to take into consideration. And regarding the volume assessment, there is one video already in the channel. So this is for today. Bye bye. We will see in the next video.